नमस्कार सर।
पॉलिटिकल मीटिंग है उसमें आते हैं वैसे आए हैं।
हाँ बिल्कुल।
हाँ, यस, दैट्स द स्पिरिट।
Good evening, doctors. I am Shailendra Meena from FDC Limited, the makers of Zocon. I welcome you all in this chapter 2 of unique webinar where we are going to cover 16 topics. For every topic, there is a master who is going to answer that. So without taking much time, I would like to introduce the moderator for the session, the eminent Professor Dr. D.G. Saple. Professor Dr. D.G. Saple is the Fellow of Johns Hopkins University, USA, and Honorable Professor and Head of Dermatology, Venerology and Apology Department, Grant Medical College and Sir J.J. Hospitals, Mumbai. He is the first dermatologist in India to use fluconazole 150 mg on daily dosing. He has delivered 1,046 lectures at national and international forums, and he has also received Best Practitioner Award at Dermacon International Congress 2019. So, but before handing over the session to him, I would like to call upon Dr. Khalil Mukaddam, who is the organizing secretary of International Dermacon 20 Mumbai Bidding Team 2023. So, sir, the session, Khalil, sir.
Yeah.
The session is yours, sir. Thank you very much.
First of all, I wish to thank our Dr. Patil sir and Dr. Saple sir and the team FDC for giving me an opportunity to be here. And again, once again, I wish to thank all of you for attending and for accepting this invitation to be here. And as you know, this initiative is for the team bidding of for the Bombay bidding for Dermacon International 2023. So, as you know, the voting is going on, and about 51% people, ideal members, have already voted. But there are many more who have to vote, and for them, it's my humble request that please vote for Mumbai at this for this Dermacon International 2023 as a venue of ideal Maharashtra. So it's a now why you should vote, that's very important. And as you are aware, Mumbai is the mega city. It is the capital, financial capital of India. It is the even the entertainment capital of India because of the Bollywood, and it's financial because of all the industries and all the industrial houses. And with this, we have come out with the best of the venue, which is in the midst of our city in BKC, and it is very near from both the airports. It's also near from all the highways, and therefore this venue is very convenient for each one of us, so that we need not waste most of our time in coming from one place to other, or wasting our time in the traffic. Therefore, I request you all that please vote for Mumbai if you are not yet voted, and this is the best place to have this Dermacon International 2023, and I assure you that we will be taking best of the care for each and every delegate. And all this my appeal is from my entire team. The organizing chairperson of it is Dr. Vinay Saraf, and myself as the organizing secretary, and Dr. Uday Hopkar, he will be also joining. He is the scientific chairperson. And we have got a large team. Even there are many more members here with of our this team. And as you can find out, Dr. DJ Patil sir, Dr. Our Saple sir, they are all in the team, and each one of you is a part and parcel of our team. Therefore, it's my humble request that this will be the best Dermacon in your life, and it will be because the venue will be best, the city will be best, entertainment will be best, and of course, scientific part will be the best in Mumbai. and from Maharashtra, as all the stalwarts in dermatology are present in Mumbai and Maharashtra. So to make a conference success, all these are the ingredients, and all this will be provided in our Dermacon International 2023. Even the food will be provided from the venue itself. All the programs, sessions, exhibition, even the socio-cultural and entertainment programs, everything will be held under one roof. And this venue, Geo Convention Center is so huge that it can house about 600 cars in the park, in its parking. And that's the reason we'll have to be here. About the food, they have got their in-house kitchen providing Jain food, vegetable food and non-vegetable food, and that to best of the food and in the most clean atmosphere and in the clean way. So, this is my humble request to each one of you, those who are not voted, please vote for Mumbai and give us an opportunity to be your host and to serve you the best possible way. Thank you very much for giving me an opportunity.
Dr. Mukadam, can I add one special this thing?
Yes.
The venue we have chosen has a negative pressure AC, and if at all require a social distancing, it will be one of the best venue. You will never see this kind of a venue when social distancing is required.
And the lift,
Yes, am I right, Dr. Mukadam?
yes. And the lift, there are about 20 escalators and more than 20 lifts, and the one lift which can accommodate about 1,100 people at a time. And even we have got the auditorium. The largest auditorium can accommodate about 11,000 delegates at a time, and there are 3 to 4 halls which can accommodate about 5,000 to 6,000 people at a time. And everything will be so smooth because this is very most modern and it's very hi-fi. All the Wi-Fi connections, it is connected, each and every corner is connected through Wi-Fi. So there will be no hassles. Even the toilet areas, everything is taken best of care. So there won't be any hassle for any part of our conference. That's what I can assure you, sir.
Khalil Khopkar is joining, or we can go ahead?
He is joining. He said,
I saw him. He's here.
I'm here, sir.
Okay. Yeah.
I'm just waiting for Mukadam to finish.
Okay, you go ahead.
Actually, Dr. Mukadam has already pitched the move, so I have nothing else, nothing more to offer. The venue speaks for itself. I would only say that the scientific program in conferences in Mumbai has always created new benchmarks for Dermacons. We know it from the last Dermacon held nearly 20 years back now, 2004. That was, I must say that it was one of the memorable Dermacons I have ever attended. And I was part of the arrangement, organizing team. I looked after the scientific section. So I would again propose to look after the scientific session of this conference if it is allotted to Mumbai in 2023. So I assure you from the scientific team that it will be the assignment we will be, which will take you to the front of and practice.
Shailendra, sound is
Are you able to hear me?
Yes. Now we can hear.
Are you okay? So just wanted to make clear the scientific aim for the future by frontiers of science and practice in dermatology. We'll have the best of international speakers who would bring you up to date with the current developments in its subspecialties, all the specialty and nearby country, we invite all that you can offer
Sir, the network is the problem,
field.
sir.
I think there are certain disturbances with the Uday. So I think because the time constraint, will request Dr. DJ Patil, who is here to bless our International Dermacon 2023 Mumbai. So I would like to have some blessing from Dr. DJ Patil. So Dr. Patil, can you go ahead?
Yes, sir.
Yeah,
Thank you
please.
very much, Dr.
Yeah.
Saple, for inviting me for this conference. And I also thank FDC Pharmaceutical for inviting me for this, chairing this session. And I must thank all my junior colleagues who are going to give us a feast of information and knowledge about dermatology, the latest things that probably very few of us know about it. And every day, the dermatology is galloping. There are new techniques, there are new methods of treatment, and there are so many things showing very good future to dermatology. When I started in 70s or 69, that time dermatology were very small and we had limited scope for anything. But today, sky is the limit, and every day there is some new technology, new technique, and new models of treatment. Now, before I go ahead, I would like to request and appeal to each and every one of us to please vote for Bombay for International Dermatology Conference 2023. You'll be happy to know that this is the Asia's biggest convention center, that is Geo Convention Center, situated in the heart of Bombay city. It can accommodate not less than 20,000 delegates at a time, and in a hall, 7,000 to 5,000 to 8,000, any number of delegates can be attended. Parking is no problem, accommodation is no problem, right from 7-star, 5-star, 3-star, and even hostels and YCMA. Each and every person can be accommodated. Traffic is no problem. There cannot be a congestion. Besides that, once you enter the venue, till morning, till night, at about 11:30, you don't feel like going out. I need not go out. Those who want to return home or hotels after 11 o'clock, they can go. Others can stay and enjoy their stay. We're going to give the best of entertainment, best of food from all over the world you'll be able to enjoy. Then knowledge, of course, there is no comparison of Bombay dermatologists and their talent and their intelligence and their way of presentation and the modern techniques that Bombay is ahead of all other cities in India. And therefore, weather will be beautiful in January and December. So I request all of you to please vote for Mumbai for Dermacon 2023. With few words, I would like you to continue with the scientific session. Please go ahead. Thank you very much.
Thank you, Dr. DJ Patil. Thank you very much again. And we'll start our scientific session. Dr. Uday Khopkar, Dr. DJ Patil, you can, whenever you feel, you can ask questions. So we'll start the program. Today's program, of course, mainly that you must have realized this is for our request or appeal for the International Dermacon 2023 Mumbai. But along that, we must learn science also. So we have many panelists. We've got almost 16 panelists in this session. So many people are surprised how you're going to manage it or how you're going to deliver the messages, but I think we have good experience. So we'll start with first lady Dhanashri. Are you online?
Yes, sir, I'm there.
Yeah. So Dhanashri, we know she's from Pune now. Most of the people all over the country know her. So I'm asking very specific question. One of the problem that is hidradenitis suppurativa or acne inversa is a problem that the patient who
थोड़ा अभी वेबिनार
suffer,
में हूँ, मेरे को कल सुबह फोन
they really, it hampers their self-esteem, their daily life. So do you think we can manage it properly, or the management is possible? And if it is possible, how do you go ahead?
Yes, as you rightly said, so this problem is not only the skin problem, but it also has lot of psychological burden associated with it because of the discharge that it produces, the foul smell that it produces, and it is in areas where the daily routine of the patient is affected. So if you have a proper kind of a protocol for these patients, depending upon the grade of the disease, then probably we can keep this disease under control and remission can be achieved in these patients. So generally, I follow the Hurley's grading system
there is a
for the patients, and according to the grading, I plan the treatment.
तो very
So
check
if the lesions are very
मी एक तासानी फोन करू का एक
Dr. Tolat, please put up your, can you, yeah, go on.
Unmute your mic. Mute your
Yeah,
mic.
put it on mute when you want to talk. Yeah, please. Okay. Yeah, Dhanasri, please go ahead.
Yeah, so when it is grade 1, only single area is probably involved and only few abscesses are there, then I prefer to start with doxycycline in a dose of 100 milligrams per day, and I continue the dose of doxycycline at least for 3 months. 3 months, and along with that, I also treat these patients with a diode hair removing laser, and this gives really good results if the disease is limited to single area and where there are terminal hair present, especially in the axillary area. I find that this particular combination works better. Now if after giving doxycycline, if I find that in about 6 weeks time there is not much improvement, then I may shift to minocycline for these patients. So this is about grade 1. Now, if the disease is little more severe, that is, if it is progressing to grade 2, and if there are more than one sites involved, like suppose the patient has disease in the axilla, in the groins, in such situations, I start them with antibiotics. There will be, and I always do a pus culture sensitivity for these patients. And though there is no infection as such, the infection is usually secondary because hidradenitis suppurativa per se is not an infective condition. So according to the pus culture sensitivity, I give short bursts of antibiotics, and depending upon the childbearing, if it is more common in females. So if the lady has finished her childbearing, then my drug of choice is acitretin, because I find that a 25 milligrams of acitretin gives quite good results in these patients. Along with that, the antibiotic that if I need to add it for a longer time, I use clindamycin. But if the patient is unable to tolerate clindamycin because of the GI intolerance, then my second choice of drug is rifampicin, of course after monitoring the liver function test and taking the necessary precautions, because all these drugs need to be given minimum for 3 to 6 months. You cannot start an antibiotic and wait for 3 weeks and say that it is not working, because you have to use it for a longer period of time to get the desired effects in these patients. And if the patient is not responding to these combinations, then I discuss the option of biologics, that is adalimumab, with these patients. And in severe cases where the repeated antibiotics are not giving good results, then I choose this option of biologics. Of course, the maintenance therapy for any of these treatment combinations is necessary, and the whole aim is to reduce the antibiotics as early as possible and continue on drugs like acitretin with monitoring of the lipid profile of these patients. So this is how I generally go about the medicines. So my choice of medicines are doxyminocycline, rifampicin, clindamycin, acitretin, and in severe cases who are non-responders, I even choose to use biologics. That is not my first option because many of the patients don't afford it because it requires a lot of maintenance therapy. And in addition to this, what I always discuss with the patient, is the weight management, because obesity is one of the most important factors which aggravates this problem. So if the patient is obese, then I also add insulin sensitizer in the form of metformin, along with the counseling for proper diet and good exercise regimen with these patients. Smoking is another factor which we need to consider even in ladies, because in India also now we find that many girls have taken up smoking. So you have to ask them directly this question. And if you have this all combined together, then probably the remission is possible. Good quality of life is what we are planning for these patients, and that is also possible with this kind of therapy.
Yeah, thank you, Dhanashri. You have made it really short and sweet, because this problem is a really difficult problem. But now the message has gone very loud and clear that initially grade 1 with the antibiotic, grade 1, 2 with the higher antibiotic, and if the grade 3, you can go for the biological counseling and the cofactor and the comorbidities. I think the message has gone very clear. So we'll go, thank you for that. Now we'll go for the next panelist, Dr. Sunil Tola.
Doc, 1 minute.
But yeah.
Yeah. Can I ask a question?
Yeah.
Yes.
A role of hormones in these conditions?
Yes, actually, the anti-androgens are recommended, but in my personal experience, the drugs like finasteride and all, even if you give it for 2 to 3 months, 4 months, 5 months, it does not show really good results in these patients. They are recommended, the anti-androgen therapy, but in my experience, what works the best is acitretin in these patients for a long-term use.
Yeah, Dr. Patil, one of my friend is doing research in gene therapy. And they said if the gene therapy is quite encouraging, and once it will be released for clinical practice, I think it may take another 4 to 5 years. So you're waiting for the gene therapy. Dr. Radhakrishnan, he is in Ohio. So we'll go for the next panelist, Dr. Sunil Tolat, who is one of the teacher in BJ Medical College. And Dr. Tolat, question is, now we are talking about uncommon condition, but the common condition, that is atopic dermatitis in children. When the children, they come, or a child come with severe atopic dermatitis, I think problem is more to manage their parents. So how do we counsel them?
Yes. So the management of the parents, basically, we have to put off the fire. If the child is miserable, the parents are doubly miserable. So the first thing in acute atopic dermatitis, generalized variety, is to make the child comfortable and reduce the flare-up of atopic dermatitis. And in such children who are extremely miserable, itching, you bring in front of your eyes a child who is oozing all over the skin, the face is red and inflamed, the hands are swollen. In this child, initially, I will start him with an antibiotic. My go-to antibiotic would be either an amoxicillin, cloxacillin combination, or I'm very fond of Fexin or Sporidex also, because it is not very frequently used by general practitioners. And under the cover of an antibiotic, I will not hesitate to give the child a short burst of steroid. I will start with the steroid boldly to the tune of about 1 milligram per kg. And in the first visit, it will be an antibiotic, a systemic steroid, and a sedative antihistamine. The most common one which I use is either Practin or cyproheptadine or chlorpheniramine maleate. And locally, cold wet compresses, soothing emollients, which are delivered a little cheaper but in a large quantity, and topical corticosteroids diluted in an emollient base, because the child has got a generalized atopic dermatitis. So I will try my best to bring the atopic dermatitis under control as soon as possible. In the first visit, the scenario is that the child is crying, the parents are anxious. So it would be a consultation where you have to give relief. And I make it a point to call the parents and the child after the course of steroid is over, initially rather quickly at the end of 10 days. I give them a separate time. I call them before all my other patients start. And that is the time when the parents are convinced that things are moving, then is the time to counsel the patients mainly about the long-term duration of the disease, the fact that the acute stage is over, that is not the end of atopic dermatitis. To explain to them that atopic dermatitis have got flare-ups, and just don't come when the flare-up comes, you have to come to me in between also, because in atopic dermatitis, the therapy is not to treat just the flare-up, but to prevent the flare-ups also and to increase the duration between the flare-up. Explain to them that this is a seasonal thing also, and in particular seasons, the things might get exacerbated, and explain to them about some food allergies also. So the second session, once the child is comfortable, is the book picture type of counseling which is needed for atopic, in which all these lifestyle modifications are needed, and wearing of cotton clothes, avoiding synthetic clothes, the bathing soap, the emollients, clean environment, using dust-free environment for the child, and how to take care of his nails and hygiene and bathing techniques, wet compresses. All this will come at the next session. And then after this is over, then I would tell the parents that you see me as soon as the acute flare-up is over, so we can plan a treatment, a maintenance treatment during the remission phase, so that the child doesn't get such acute exacerbation ever. And then that is the time I even counsel them about a little more expensive medicines. And I keep in mind cyclosporin as my next drug if the flare-up is not controlled, and I get my lab ready. If in case the steroids are not working too well, I would also, under the cover of steroids, start cyclosporin and slightly taper the steroids. So then is the thing which we all do, that play around with the topical steroids, reduce their potency, dilute them, give a steroid-free interval. And the moment the flare-up has gone, then is the time to introduce the tacrolimus or pimicrolimus. And this is tacrolimus, pimicrolimus. They are not very dramatic drugs, but the main role that they play is in increasing the interval between the flare-ups and giving them a bigger remission period if they are used when atopic dermatitis is not active. So briefly, this would be my management, day-to-day management in a child of atopic dermatitis who comes to me initially with a severe atopic.
Dr. Tholak, thank you. You have brought very important point that the patient should be called when you are free. There are no other patient. That is a very important point, because most of us, we know what are the medicine should be used, but there is very another important point. When the disease come under control, the parents, they become complacent. So don't allow them to become complacent. See that they have to come with a regular, continuously, even during the remission period, they have to come. So these are the very important 2 points. And as you said, we have to use immunosuppressive drug like cyclosporin and steroid, but we can add biological, but that is in a rare cases we can nowadays use it. Thank you for that. So we'll go for the third panelist, Dr. Dinesh Oswal. Dr. Dinesh Oswal is from Baramati, Solapur, no? Yes.
Baramati, sir.
Pardon?
Baramati, sir.
Baramati, yeah. So Baramati is well known to everybody. So Dinesh, we are talking about the common problem, that is you are in a cosmetic practice. Acne almost, the young people, teenager, almost each and everybody, they come for their advice. So what is your advice? Any patient of acne vulgaris comes to your clinic, because this has become very common.
Thank you, sir. Thank you, sir, for allowing me to interact with the audience. As I know, I practice in rural areas. Most of my acne patients are youth and young adults. Girls are brought to us only before marriage, and most of these youths are, impressed with the advertisement where some of the magic product is shown to give you a spotless face. So they expect a dermat to clean his or her face with a magic remedy in 1 or 2 sessions. And as of all of us know, the success of the acne treatment is the adherence. So foremost important thing what I do in my practice is to counsel them that the acne problem cannot be fixed in 2 or 3 weeks time. It takes time. I explain them the biology, pathology of the acne, spend at least 10 minutes in the first visit, explain them the steps of the treatment. For example, आपण सुरुवातीला मोठे फोड करूया, नंतर छोटे फोड येतील, नंतर स्टेज येईल डाग घालवण्याची आणि नंतर खड्डे घालवायचे. सो आय मेक देम अंडरस्टँड व्हॉट आय एम डुईंग इन ईच विजिट. So this discussion also helped to bring down the unrealistic expectations of the patient, and also try to clarify the misconcept about the causative of the acne. Uh, then, and I'm very proud to say that with this counseling part, which is the most important in the management of the acne, and I'm proud to say that most of my patients they complete the treatment till their satisfaction. The fallout rate is very low. Secondly, all of us know that cases of hormonal acne, that PCOD is rising in girls. In boys, very high protein diet and gym supplements are causing very high percentage of the bad acne. Steroid combos is another big menace, and that's why the first visit, the importance of diet, avoiding the high glycemic index food, and importance of the exercise, and avoiding all steroid supplements and steroid cream. This is the time I should take this opportunity to explain them all importance of all these things. Thirdly, the sun exposure, sir, is very high. The lifestyle in the rural area make them, the sun exposure is very important, and many of the patients who fall out of the treatment, that is because of the increased tanning and darkening of the face with one skin specialist. And such patients, they come to us complaining of darkening of the face as soon as they start treatment. And most of these patients, acne patients, they are receiving either topical or systemic steroid, and then you come there peeling and lasers. Each of this factor is the sun protection is very important. So I make it a point to explain them the importance. I ask them, to use physical sun protection, like using caps and hats, in addition to the sunscreen. One more important thing I explained in the very first visit, that the maintenance treatment is going to be very important in this patient. As we all of us know, acne is chronic disorder of pilosevisis in it, and to avoid the relapses, as soon as I finish my all the initial steps of controlling acne and pigmentation because of acne, I put them on intermittent or say bi-weekly or thrice a week topical retinoids, your oil-free moisturizers, and non-comedogenic deep cleansing agents. And so with this, my patients, they keep on visiting me with their clean and clear faces, say once or twice in a year further for maintenance, and they are very happy. So this is my strategy in assuring the adherence of my patients, so as to complete their complete course of treatment. Thank you, sir.
Yeah, thank you, Dr. Oswald. Dr. Oswald has given the very good message that many patients of acne, they come when they need like the marriage for the function. So our dermatologist duty is to make the awareness program that acne acne has to be tackled, and the second point, early, and second point you made it very is a long term treatment. It's not treatment 1 month or two, it can be 2 years, 3 years, a long term. And thirdly, he has given the message that bring acne under control, maintain them, and prevent them. And that's how you could treat, and that's how he's enjoying, and he's finding the compliance of the patient is very good because of the counseling. So thank you very much for Dr. Oswal. We'll go for the next panelist, Dr. Rashmikant Shah. Are you available?
Very much. I am available.
Yeah, okay. So Dr. Rashmikant Shah is a national vice president of IDVL. We'll ask him a very common question. He is doing a lot of work on dermatophytosis. So Rashmikant, there are a lot of patients with delayed response, relapse, recurrence. So how do you manage these refractory cases of dermatocytosis?
When you say it is relapse, delayed response, I think it is more of a clinical failure rather than a resistance. And in this case, I use fluconazole nowadays very often. In most of my patients, last say 250 to 300 patients, I have put them on fluconazole 100 milligram per day for 4 to 6 weeks time. And believe me that the relapse rate after almost around 3 to 6 months is only 4 to 6% compared to itraconazole, which is more than 10% in many of them. Clinical failure is much more common in terbinafine and itraconazole. Fluconazole doesn't do that. And some people would ask that why we use 100 milligram. I think 100 milligram is better dose, and we have experience from our HIV medicine. We were using around 400 milligrams per day for histoplasmosis, cryptococcosis, and the generalized candidiasis, and we have found there is no much of a side effect. Number two, the interactions, drug interactions are much lesser compared to itraconazole. And the most important thing, you do not require to give fluconazole along with the food or fruit juices and so on. You can take otherwise also. So my first choice today is fluconazole. Of course, I don't say that you everyone should use fluconazole, but this can never be eliminated. I think fluconazole is very much effective. Everyone should try it now. Everyone should try it now, and do not neglect this drug at all. And counseling part, it is very important. When I say that it is recalcitrant uh, disease, then counseling is very important. Like any other disease, everyone say last four speaker, all of them talked about counseling. So even in this year disease, you do require a counseling. And if the patient comes for the first time, if you give fluconazole, you would be able to change the relapse rate. Dr. Saple, my message is very clear. Fluconazole is very effective.
Okay. Rashmi, thank you for sharing your experience. He has made it very clear. Most of the patients who come across, they are of a clinical failure rather than resistance. That is the first point. Second, he said the most of the people who can afford systemic antifungal is fluconazole. Of course, he says that itraconazole, terbinafine, they are effective, but fluconazole is cheaper drug. Mass people can afford, and the results are better. And of course, compared to other drugs, fluconazole is a better drug as per the cost-wise concern, the potency is concerned, drug-drug interaction concerned, and convenience concern. So that is the experience of Dr. Rashmikant Shah. Even I'm working for last 3 years. I entirely agree with him. So now we'll go for the next panelist. Next panelist is Dr. Dipti Desai. Dipti is attached to Medical College in New Mumbai, and she has got large experience. She works with the team with this vulval problem with Dr. Neena Madani. So, Dipti, what are the common problems do you see in your clinical practice? What I mean is the vulval common problems.
Yes, sir. Thank you, sir. Thank you, webinar organizers, and good evening to all of you. Now, coming to talking of what are the common vulval problems and how they present in our day-to-day practice, I would say that the commonest way the patients present to us is with pruritus vulva or the vulval itch as it is known as. The most common symptom is that the causes are infective as well as the non-infective. A very common diagnosis we can make is about the vulvovaginitis, candidal vulvovaginitis being a very common one. we need to differentiate from the trichomonal and also from the bacterial vaginosis and the vaginitis. Now, which is more common in children. And many a times we see that the children are treated with the other antifungals, considering that this is a candidal one, which one should refrain from. And then one should have a pH strip and the swab, which should be handy in our clinic to come to a proper diagnosis. We all know that we have to see what kind of discharge and whether it is copious or curdy, and then how we take the swab and diagnose. But then the thing is that many a times we see that this vulval itch, which they present with, which could be, due to so many other reasons, like, it could be a lichen planus, it could be a psoriasis, it could be eczema, it could be sclerotic problems, and many a times without any investigations, we can come to diagnosis. Sometimes even vulvar warts can present just with pruritus vulva. So what is very important is the thorough examination of the vulval area as well as the other parts of the body, which is important. Now, what happens is that if a patient comes with, certain complaints like there is a white patch or a discomfort at the vulval area, and we often see that, on examination itself, we can make out many a times that this is lichen sclerosis, and we can offer a lot to them if they come early. This should be differentiated from the vitiligo. Obviously, there are other parts we have to examine, and we have to look for certain signs from there. So even without taking a biopsy, we can come to certain conclusions and offer the best.
Deepti, can you go for the common problem?
Yes.
Like vulvovaginitis, the common cause is the candida, correct?
Okay.
So how do you manage candidosis?
All right, sir, I would come to that. Just a few things what are common. We'll just complete that. So this is one vulvar pruritus. The other, group of patients come with painful ulcers to us. And that is like, many a times we see it could be venereal or non-venereal, but this could be commonly herpes genitalis, it could be aphthosis, it could be erosive lichen planus, Behçet's, or some drug. So the history is very important and the examination. And sometimes we need the biochemical investigations like the complete blood count, the sugar, the thyroid check, and sometimes the LFT and the KFT to arrive and to, rule out certain metabolic causes. But if you want me to say more of the candidal part, then we will just cover that part, that the candidal vulvovaginitis is one of the commonest which we encounter, and the treatment should be according to, if it is a simple one which they present with, it can be treated either with the topical or the oral. The topical agents like the 1% clotrimazole, 2% miconazole, or butaconazole, these things, we can just help the patient with simple applications without oral tablet. Or it could be a single tablet of 150 milligrams of oral fluconazole can give complete relief to the patient. But when there is acute severe kind of vulvovaginitis, when the patient has a lot of, the symptoms they come up with, the discomfort, then we need to follow the guidelines which is given by the association, and that is like 150 milligrams of fluconazole should be repeated every 72 hours for 3 doses. And if this happens to be a recurrent vulvovaginitis, then it becomes challenging. At that time, we need to offer them a inducing dose of 14 days, and that should be given for continuous 14 days of oral fluconazole tablet 150 milligrams every day, and then weekly doses, again 150 milligrams, to be continued for 6 weeks to even 6 months is recommended. And this would give complete remission. Now, just to add a thing, that all these vulval problems, sir, we can offer a lot to the patients. Unfortunately, they come late to us. And as Dr. Nina has always said that, every vulval problem is treatable. Let them come early to us. We can offer the best. But even if then, we are always there, we can give them a lot of relief in the symptoms, and they're improving the quality of life, their social, their sexual, their professional. All these lives are getting affected because of the vulval problems, which are not properly addressed. So dermatologists have a key role in playing in this, giving them relief and taking satisfaction in giving relief to our patients. So, and that's the message I
Yeah,
want to give.
okay. Thank you, Dipti. I
Thank
think
you.
Dipti, again, she has made a point that dermatologist has to make the awareness program that vulvovaginitis has to go to dermatologist more than go to gynecologist, because many times they go to gynecologist and gynecologists are not well trained, but we have to sensitized to all general practitioners or other faculty. Otherwise, they send it to gynecologist. Invariably, they send it to gynecologist. That is the first thing. Secondly, the common problem in vulvovaginitis is the cause is candida in adult. In children, usually it is a bacterial because of the pH, and the treatment is drug of choice is fluconazole. But in the refractory cases, it can go for 3 months to 6 months. Many times, when you start treatment, patient feel better, patient may not come, and even you may not lose interest. So it should not be like that. It has to be long-term treatment. Correct, no, Dipti?
Yes, sir,
Yeah,
absolutely.
so it's a very good message. Now
Can I
we'll
make
go.
a point,
Yeah,
Dr.
yeah, yeah.
Saple?
Yeah, please. Yeah.
I think 2 points need attention. Number one is the contacts, like perfumes, clothing, hair removal,
Yes,
intimate,
Yeah.
scent,
yes,
etc.
Allergy, yeah.
And number two is the psychogenic. Many
yes,
times it is
psychogenic
psychological,
pruritus.
like in simplex chronicus. That needs, other than bacterial and candidal conditions, fungal conditions,
Absolutely,
these
sir.
also need
In
attention.
fact, that was on the list, but sir just wanted me to address the candidal part. You rightly said, sir, the irritant contact dermatitis, and which is so common, in overzealous parents who actually, treat with, apply certain cleansers and products for the babies,
Yes.
besides the diaper thing, and also the teenagers who are today using a lot of washes for the vaginal area. They also come up with irritant dermatitis, contact dermatitis, and the psychogenic pruritus, of course, a good number of patients come with that. Yes.
Should I make a point?
Yeah.
So basically, to catch hold those patients of the venereal area or venereal part, we need to have our OPDs friendly for this part. So I always said that the privacy friendly clinics or the privacy friendly consultation rooms are required. So most of dermatologists, they are not equipped with vaginal examination, a female attendant, the equipment, the speculum, maybe the other things, they are not very handy. I think unless we gear up our consultation room to examine the patient's private part, we will miss most of the time patient talk of itching in the perineum and we blindly prescribe an antifungal cream. So I think we need to equip our consultation room to examine these private parts.
So Dr. Depe has given this suggestion, you should have specialized room. So for that contest, I'll go to another panelist, Dr. Dhananjay Chavan from Karad, now Pune. Not only Karad, is Pune. So Dhananjay, because I know you for long. Initially, you were interested in HIV, used to come and interact. He wanted to develop, then he developed cosmetology. So you have become one of the successful and progressive dermatologists. So can you share your experience?
Yes, good evening, sir, and everyone. For last 34 years, I'm in dermatology branch. And in these 34 years, we have seen all the eras. That means sexually transmitted diseases era, leprosy era, HIV era, routine conventional dermatology era. And things are changing. In last 34 to 40 years time, everything is changing. We have gone through all these changes. Our practice is changing. Initial days was like that. The person who is having very big degree from Mumbai or any reputed college is having lot of credentials and all this thing. He used to be very famous doctor in that area, and people used to wait for him to get his appointment. But nowadays things have changed. In last 10 to 20 years, everything has changed due to internet and due to this generations changes in generation. We are from baby boomer or generation X, millennial, generation Z, and now generation alpha has come. So everyone is techno savvy, and we have to change ourselves to techno savvy. We have to become techno savvy. We have to come on internet. We have to educate the way we are trying to educate our colleagues and trying to discuss and holding some seminars for our colleagues and for our branch only. But now people expect we should go in them and we should explain each and everything to them. So practice is totally changing. Way of practice is changing. Only thing you are brilliant, you are boss in that field. No, it is needed. Your intelligence, your diagnosis, treatment, everything is needed. That is basic need by patient. But overall experience of the patient, starting from whenever he think for any dermatologist, he should be easily available on internet. He should be easily available on social media and everything. So our branch presence should be there. Otherwise, you will be sidetracked. You cannot now rely only on your talent and your degree and everything. You should go to the people because they are having enough options. So practice is changing. All different lasers, light, technologically updation has occurred in our practice. The same way, we have to spread the knowledge to the patient. We have to go to the patient with knowledge. And we have, now see, website is mandatory, social media presence of doctors is mandatory. You should be in the mood to give everything to the patient in the form of knowledge, blogs, videos, question answers, everything. Before coming to any dermatologist, more than 75% patient, they first go to review. They try to review that doctor, how he is doctor, what are the reviews of his clinic, what is review of that doctor, how much he is contributing to socially, how much he is making people aware and all this. So these new changes along with changes in our branch, even biologicals has come, advanced treatment has come, and everyone is now cautious about their personality. So world is changing fast. We have to change fast. We have to come with very best clinics so as to, because taste of patient is changed. They want everything best. They want everything clean, clear, and everything like that, fresh and safe. Safe, effective treatment is required, and you should go to the public. So this is the major change that has occurred in our brand.
Okay, thank you, Dr. Chavan. And Dhananjay Chavan has made it very clearly. You have to be good clinician. Basically, you have to be a good clinician, but don't be under impression because I have been trained abroad, because I have got a high degree. Patient will come; those days are gone. So you have to get on social media. You have to change your attitude. You have to make patient comfortable. So a lot of messages has given. I think Dr. Dhepe is waiting, but I'll ask you later. But Dhananjay Chavan has made it very clear. So we'll go for the next panelist. Dr. Amit Shah has joined from Sangli. Amit. Gautam, Manish Gautam, have you joined?
Yes, he is there.
Dr. Nikam.
Yes, sir, I'm there.
Yes, sir, I'm there.
Yeah, Manish is here. Manish is well known because he works for Ideal Maharashtra for many years continuously. So doesn't need any introduction. So another common problem, what we see is a pigmentation, facial pigmentation. But to cover facial pigmentation will be very difficult. So I'm asking you a very difficult problem. Lichen planus pigmentosus, do you have any solution and how do you manage them? Because that day I was discussing with one of the senior dermatologists He said give vitamin C and apply vitamin A and you get beautiful result. But that was his experience, but I would like to hear from you.
Right, sir. Thank you, sir. Thank you for having me here and thank you for those kind words. Coming to lichen planus pigmentosus, as you rightly said, sir, it's a very, very difficult condition to treat. And we have learned from our seniors like you, Dr. Torsekar, and everyone, that if you have too many options to treat a condition, then it is almost not treatable. That is what most of the time the things with the thing, when there are many options are available, generally it's not a very treatable condition. But yes, lichen planus pigmentosus is considered to be a variant of lichen planus, sir, because there is been a picture which is histopathologically similar to lichen planus. There is the most of it is an actinic variant most of the time on the face, but you do get sometimes an inverse variant to it also. So my first approach, because it's an actinic variant, is to first thing is for sunscreens and oral antioxidants, which definitely are going to help. The second point about this particular disease is that it is like more of a burnout kind of a thing. It is an after effect of a disease because there is not much of inflammation involved. You just see the post-inflammatory picture, that slate gray kind of a pigmentation, and there is no activity. So most of the things which would work in active lichen planus would not be very useful in this particular thing. So it requires a lot of hand holding and counseling again, because that is one thing which will take a long way in treating this not so easily treatable condition. And if at all, it is known to be a type 4 hypersensitivity reaction to an unknown antigen. And sir, it has a lot of overlaps, we would say, with pigment contact dermatitis. So many a times I try to look at those triggers, sir. And I have seen that even if people would say LPP is different from PCD or from erythema dyschromicum perstans, but it is still got an element where if you stop the triggers like a hair color, or for that matter perfumes, in males an aftershave lotion, in addition to whatever protection that we are talking about, that also helps a lot. That is one thing which I have been trying and with found reasonable success. Coming to other modalities which I generally employ during this treatment is, again, as I said, I learned from my seniors. There is xanthan nicotinate, which Dr. Torsekar used to use very beautifully in combination with oral vitamin C, and sometimes even a little bit of amitriptyline, sir. I don't know, amitriptyline not here in this condition, but vitamin C and xanthan nicotinate in a patient who doesn't have any other comorbidities. This gives a lot of difference in the pigmentation. There is definitely, even though it's a dermal pigmentation, it reduces to some sizable extent in these patients. So this is one more approach which I differently follow, because you asked me what I generally would be doing in this.
Correct.
Yeah, and avoidance of triggers, as I always said. Then dividing the patients into whether a patient is in the area where there is a cosmetic requirement for his treatment, because there are patients who would be in the age group which they would say ki doctor थोडंफार कमी झालं आणि हळूहळू कमी झालं तरी चालेल. But there are certain people, younger people, who would require a little bit of an immediate kind of a treatment or something which would be more useful. That's where we try our Q-switch NDI, sir. The Q-switch NDI 1064 with a low fluence, it works very well in these conditions. Of course, in addition to all the other treatments which I was talking about. So these things are definitely going to help. There have been roles of topical steroids. They have been used, and even topical tacrolimus. 0.1% tacrolimus has shown response. But what I believe is most of the times the avoidance, topical steroids for some time, and if at all lasers, they will be definitely useful. But I think most of the time we have to tell the patient that it's going to take time and it is going to be a little bit of a slow process. One more thing, sir, just want to add is to understand what is the prognosis of it. If we do a dermoscopy, when we do a dermoscopy of these lesions, if we see more of a dotted kind of a pattern, there is generally a dotted pattern, there is a diffuse pattern or a mixed pattern. When you see a dotted pattern, you are likely to end up with a persistent case. So we can, understand and try to convince the patient a little differently when we see the dermoscopic picture being to be on the dotted pattern. And inflammation being not there in this process, we have to gradually and slowly take hold of the patient and try to get rid of the problem. But these are certain things which I try to incorporate and see to it that the patients are being taken care of, and once gradually they can start getting better. These few things are there, sir, and it has an unpredictable course. So many a times it is difficult to know which one would persist more and which one would go earlier. So that is where dermoscopy would help us, sir. This is my approach to a case of LPP. But as you rightly said at the outset, it is not a very easy nut to crack. So that is how I would go about treating it.
Thank you, Manish. I think all of us will agree this is the condition where you are not able to satisfy patients or patient are not satisfied. The day will come, we'll keep on trying, we'll be able to reach to that condition. But Manish has made a very, very good point, that is dermatoscopy. Dermatoscopy will help you to just give the prognosis. So everybody should remember about the dermatoscopy. And another point, the actinic variety and the inverse variety. So actinic variety is usually is very common because usually they come on the exposed part where sunscreen or anything which prevent the actinic effect, that will be help you. Thank you, Gautam. So we'll go for the next panelist.
Thank you, sir.
That is Dr. Balkrishna Nikam from Karad. Dr. Nikam is very good in dermatopathology, like Dr. Uday Khopkar. I hope Uday Khopkar is listening to it. So, Dr. Nikam, I'm asking very simple question. When you give a report, do you have clinical correlation with the dermatologist, or you give most of the time you just give report by looking at the microscope?
Sir, there is an advantage of being a dermatopathologist that we are first dermatologists, and so we have a good clinical knowledge about the disease which pathologist doesn't have. So what happens when we look into the microscope, if it is suppose it is a tumor, so it's a clear histopathological diagnosis. Here the clinical information definitely help us for the correlation or differentiation of the tumor, or for the confirmation of the tumor. Like you say, if we are seeing the histopathology of hydranoma papilliferum and the clinical site is vulva, so it's clear that this is hydranoma papilliferum. Or if you are seeing a case of histopathologically trichoepithelioma and the clinician is thinking syringoma, so here the diagnosis is histopathological, so it's clear that it's a trichoepithelioma. So discordance in tumor is in more favor of dermatopathologist, because here the dermatopathologist report will be the final. But then it comes with the inflammatory disorder. When we look into the slide without any clinical information, most of the time it's a guessing game for dermatopathologists. So we diagnose almost keep a differentials of two to three differential diagnosis, and at the same time then we call the clinician and ask him regarding the age, then the duration of the lesion, then associated pruritus or not pruritus, and what's the clinical what are the histopathological differential diagnosis and what the clinician is thinking. Majority of the times in such cases we need to correlate it with the clinical photographs also, and then we need to give a good clinical pathological correlation diagnosis for the clinician, to which the clinician sometimes, many times accepts, many times he may reject the diagnosis also. This can happen with many times, and in such cases we need to keep the follow-up of the case also. So what is important is to see the photographs or clinical photographs after seeing the biopsy or histopathology is more important in inflammatory disorders like spongitic diseases, or even lichenoid diseases, or even the granulomatous diseases, because sometimes the clinician thinks it's a psoriasis and histopathologically it shows lichen planus. In that case we have to ask for the photographs, confirm that this is lichen planus, and convince the clinician that this is lichen planus histopathologically also and clinically also. Second important thing, nowadays, many of the clinicians are calling me before doing the biopsy, sending me the photographs and asking me the which will be the right side for the biopsy, because many times they took it from the wrong side. So that's another good thing that recently happening before, that is called as a preclinical pathological correlation, and it definitely won't cause any pathological biases which earlier used to be thought. And third important thing in clinic CPC is that we need to follow up the case after giving the treatment. We need to ask the clinician what has happened to the patient after the treatment, so that whether our diagnosis which was given, which was in discordant with the clinician, or which was very atypical.
So, Dr. Nikam, you like to interact with the dermatologist who are referred or who have sent a biopsy to you. But
Yes,
what is the percentage? Most of the patient you see their clinical photograph and correlate. But
yes,
what is the percentage you have to talk to them personally?
sir, it is almost 30 to 50%.
Oh, 32. I entirely agree.
And this I have learned from my own boss, by Dr. Wadhwa sir. He used to be a very good clinician, and Dr. Khopkar sir is my boss for histopathology. And they used to discuss the cases in front of us. So that is how we learned the clinical pathological correlation is a gold standard in every case. And that is how we are following the same this method till today.
Entirely agree with Dr. Nikam that whenever you have problem, instead of referring to the even the top pathologists, refer to dermatopathologists. They understand better. I'll give example. Dr. Wadhwa and me, myself, we are attached to Bridge Candy Hospital. One of my patient who came from Nairobi, she was diagnosed as Steven Johnson syndrome. We are admitted in ICU. We did a biopsy and sent it to pathologist. The report was not coming 24 hours, 48 hours, 72 hours. I said, what is happening? They said, sir, we are not sure. I said, I'll come and see. When I went there, I said, this is the pemphigus vulgaris. You know, because during my registrar post 2 years, I used to go and sit with the pathologist. 2 years continuously. 2 to 4, I used to be in the pathology, of course. So what Dr. Nikam is saying that it has to be referred to dermatologist, and there is whenever there is doubtful. Ask Dr. Khopkar. He is my neighbor in practice. We are practicing both at Dadar, but I refer my all cases for dermatopathologist Dr. Khopkar, and he keeps on telling me, I hope he's listening. He said, sir, you are the only person keep on troubling me that whatever the reports I have given, I'm not happy. Anyway, so we have to take the advantage of dermatopathology, which is quite a growing branch. Thank you, Dr. Nikam. Then we'll go for the next panelist, Dr. Sunil Patwardhan from Satara. Sunil and we are working for long, almost 20 years in the field of HIV. So Sunil, there are a lot of progress, but one of the any HIV discordant couple comes, one of the problem they are facing is the natural sexual practice. So do you think, is it possible with today's knowledge or today's progress of the disease? Yeah.
Thank you, sir. At the outset, let me wish you all a happy Koshagiri Purnima and Eid Milad to all of you. And today also happens to be a blue moon night. Coming to a question. Now, as we know, a discordant couple is the one where one sexual partner is HIV positive and the other is negative, right? So in 2018, UNAIDS came out with the concept of U is equal to U. Now that means that undetectable is equal to untransmissible. Now this was based on 3 real world epidemiological studies. Now this U is equal to U, it means that if a person's HIV viral load is undetectable, he will not be able to transmit the infection. Now, this was a great news for the HIV positive community because they felt that they could enjoy sex without using a condom. Also, they felt that it will reduce the stigma associated with HIV. Now, but there are 3 caveats in this. One is that a person has to have undetectable viral load repeatedly. Second is that he or she has to be taking ART very regularly. And third is that this particular document it uses the word negligible transmission, not zero transmission. Now, in our scenario, the way our patients are type of patients we have, where we are not doing very regularly because of the cost. Secondly, the patients are not always very regular in taking their ART. So personally, I won't recommend the use of condom. Recommend not to use the condom in all the discordant couples without the proper counseling. And also, during counseling, I have to tell them that the chances of STR transmission are still there. So it's better to keep on using a condom. That's what I feel. Although this document is saying something different. That's all I have to say.
Sunil, thank you for sharing this. And it's absolutely right. In today, that if a viral load is undetectable, that is less than 20 copies per ml, the chances of transmitting to partner is almost all zero. But there is a rider on it. Those patients who are going to have a natural sexual practices see that the adherence of the antiretroviral therapy, as Sunil said, has to be very good. And secondly, their virus load has to monitor very frequently, not after 6 months or after 1 year, because they are not using any barrier like condom. I remember in 95, we worked with Thomas Quinn from Johns Hopkins in 95, and that time our paper was, your virus load is less than 1500 copies, you do not transmit to your partner. That was in 95 with Dr. Maniar, myself, JT, and Thomas Quinn. But anyway, now the world has accepted the virus load is under control, undetectable, they can have natural. Thank you, Sunil, for that. So we'll go for the next panelist. Next panelist is Dr. Aditya Mahajan.
Yes, sir. Hello, sir.
Yeah, he is there. Okay.
Hi, sir. Yes, sir. Hello.
Aditya is son of Suresh Mahajan. Suresh Mahajan and me, we were contemporary when I was registered. He was houseman. Dr. Torsekar was there. Dr. Golia was there. All we were from the JJ. So Aditya, I'm asking very nice question, which is very important question. What are the common conditions do you see at Satara? Because it depends upon place to place.
Yes, sir.
What common means? Common dermatological
Yes, sir.
problems.
Sir, yes, sir. So I would first like to thank you all for including me in the program today. So as you all know, I practice in a rural setup. So here we are seeing a lot of fungal infections every day. Also with that, due to the large amount of farming as the occupation, I'm seeing eczemas, palmoplantar psoriasis, a few cases of prurigo every day. One more common complaint which I see in practice is pigmentary changes due to continuous chronic photo damage, which can include a condition like melasma or hyperpigmentation due to excoriated acne, etc. There are also nowadays the number of cases of topical steroid abuse over the face, groin are increasing. That can be due to use of over-the-counter fairness creams or fungal infection, etc. Acne is also very common. Coming to cosmetological part, tattoo removal is very commonly done here because young students, they want to get into army, navy, air force. So there they need to do removal of the permanent tattoo marks. In the last few years, there is an increase in cosmetological complaints like hirsutism, acne scars, hair transplant, hair loss. We are seeing, sir. And last but not the least, parents who bring to us their daughters and say, "Ki sir, iska rang thoda ye kar do, fair kar do. She's dark." That is also increasing nowadays, sir, because of this
Okay. Yeah, thank you, Aditya. I think you have made it very clear. Even you are practicing rural area where the problems are different. We were expecting probably you'll be getting a lot of infection, but the problems are, of course, you mentioned about the dermatophytosis, but you said because the farmers, their problems are different, contact dermatitis, pigmentation, and even they are interested in cosmetology. So you are given the message, even you practice in rural area, the dermatology has to incorporate the cosmetology in their clinical practice. Am I right? That is your message?
Yes,
Yeah.
sir. Yes, sir.
Yeah.
True, sir.
When
Correct,
you
sir.
are seeing the dermatophytosis,
Yes, sir.
usually what are the systemic drug you are using for a dermatophytosis? Because that
Sir,
is
I'm
problem.
personally, I
You
like
are
to use
not getting
Hatrac.
good results. Yeah.
Yeah, true, sir. Sir, I like to use Hatrac Conazole 200 mg every day. That is my first drug always. If there is any relapse or if there is any recurrence, I would like to add terbinafine along with it. Terbinafine 250 mg once a day or rarely 2 times a day. Fluconazole, sir, I am not using very frequently, but I intend to start now that Harshmikan Shah sir has said that fluconazole is giving the results are good. So I'm thinking of starting it again, sir. But mostly it is hetraconazole and terbinafine.
Okay. Thank you, Aditya. Of course, Rashmikant has given because the cost, of course, there are other factors there, the cost. I
Yes, sir.
think it definitely it
Yes,
will
sir.
help
Cost,
the
yes, sir.
rural area. So now we'll go for the
Yes, sir.
next, Dr. Amit Shah
Thank you.
is available.
Yes, sir.
Yeah, it's very good. Amit Shah is practicing at Sangli with his father Bharat Shah. But I visited their clinic and I keep on telling everybody, if you wants to set up your clinic, you must visit his clinic. Is I was impressed the way the father and son, they can interact with each other if they want to discuss very easily. They gone from each other's room, the waiting room, everything was very nice. Even Aditya Mahajan and his father, I just suggested, if you are renovating your clinic, you must go and see their clinic anyway. Amit is very much interested in vitiligo because vitiligo is a social problem, social stigma. So, Amit, what is your experience about the treating vitiligo?
Yes, sir. In my area, there are many cases of vitiligo. Particularly focal vitiligo, I usually start the topical therapy. And of course, in each and every case, before starting therapy, I usually counsel them. First meeting, counseling is very important because most of the time, the patient as well as the family members, they come up with a lot of stress. As you said, there is a stigma also. And there are very different complaints from the heredity is very much the problem they face. They think that it is 100% heredity. So some misconception have to be removed from their mind. Some confidence has to be given. So in the first meeting, counseling about the disease, and I usually tell them that this is a disorder of melanocytes and it is not a disease per se, and it is a treatable. It does not affect your physical health as well as it does not affect your reproductive system. And as far as the heredity is concerned, it is only 50 to 20% heredity. So that gives the confidence. As far as treatment is concerned, for localized vitiligo, I usually start with the topical therapies. I'm very much fond of laser, exam or laser. Those who can come weekly to my clinic, I usually add examer lamp, monochromatic examer lamp, which gives fantastic result, particularly on the face, neck, trunk areas. Uh, Even the segmental vitiligo, which is resistant to many of the treatments, I have found good results in combination with topical tacrolimus and examer lamp. As far as considering the generalized vitiligo, I usually find that if it is unstable, I try to stabilize the disease with either narrowband therapy or Uvasol therapy. Because in my area, the ample sunlight is there. Many of the patients cannot come for weekly for the narrowband UVB. I usually recommend Uvasol therapy. And nowadays I'm using, instead of 8 MOP or 5 MOP, I found kaolin and phenylalanine combination very equally good, and the phototoxic effects are very less. Even we can use it in children, because 8 MOP and 5 MOP we cannot use below 10 years. But kaolin, phenylalanine can be used. It is old drug, but there are quite good results, comparable results with the 8 MOP or the 5 MOP. I do use azathioprine, and I do use, in initial phase, I do use steroids in pulse therapy, which help in stabilization. Those who don't respond or they are resistant to the medical line of treatment, I go for surgical management, particularly for the non-appendageal aerial skins like the ankles or the knee joints. I usually prefer cellular grafting, that is melanocyte non-culture cell suspension, instead of the tissue grafting, because this new technique, that is a cellular grafting, gives quite good color match, the textural, the effect in, and the color cosmetically is very much similar to the surrounding skin. And also we can cover the larger surface areas with the small donor site, around 5 to 6 times we can cover from the donor site. So that are some of the advantage of the cellular grafting. And after the cellular grafting, I usually again put them on the excimer, which again gives a faster repigmentation. That is how I treat the vitiligo in my area.
Thank you. Thank you, Amit. I think you have covered very nicely. The patient comes, the initial stage, then the laser, then the skin grafting, and after that cellular graft. So you are happy with the cellular grafting? The results are good?
Yes, sir, very much. As compared to the tissue grafting, the color match is very good, and it can be done to the most of the areas, including the flexures, including the hairy areas, where the tissue grafting is a problem, where the graft rejection chances are there, and the cosmetic color match is very good.
I think most of the patient coming to your practice must be before marriage, or what are the problems they come?
No, basically, yeah, the second and third decade, it is very much common. And definitely they face the problems about the marriage, because in our society, the stigma is there definitely about the vitiligo. And as I said, they think that it is 100% transmitted to the next generation. So first counseling about this misconception has to be done. And then the confidence the patient gets. And if they are of the marriage going age, definitely we start with the combination therapies, like excimer laser, immunosuppressives. And if they don't respond, then we can do those areas which are not responding can be treated with the cellular.
Yeah, Amit, now you're practicing for many years. How much you are satisfied treating these vitiligo patients as per the relapse and recurrence is concerned?
Relapses are there because this disease is with unpredictable course. I usually explain patients in the first visit only that this disease is a long run disease with stages of stable and unstable phases. So definitely almost 20% to 25% the cases they do relapse even after total repigmentation. So that has to be explained, and that has to be kept behind the mind.
Okay, thank you, Amit. Now we'll go for the next panelist, Dr. Nitin Depe. Nitin, are you available?
Yes, sir, very much.
Okay, I think Nitin doesn't need any introduction at all. I've kept him second last. The reason being, we are expecting a lot of things from him because he is very versatile. And I should not mention, but I don't mind mention, I was one of his examiners for MD. Am I right, Nitin?
Yes, sir, very much.
Okay. So we want new generation. What is your message about the cosmetology and as per concern with the laser, because the cost is the big problem. So we are expecting some positive messages from you.
Okay, so about the cosmetic and the laser practice after COVID, if you are asking in that context, I actually put forth my theory that the COVID has made the dermatology practice to move in the retro direction. So like how the dermatology practice evolved from a consultation practice to the consultation and pharmacy, then consultation pharmacy plus dermatosurgery, and then came the cosmetology. So everybody will get a setback of moving one stage behind or two stage behind. Those who are in the cosmetology, they will have the more of the need-based procedures. Those who are already in the dermatosurgery, they will have the heavy load of the prescription and the pharmacy and less of the procedure. So everybody will have a one step setback. So what is the key message after the COVID? That focus more and more on the need-based procedures than the cosmetic procedures. So if you are equipped, so if you are only in the pure cosmetology, learn the dermatosurgery procedures. If you are in a dermatosurgery procedures, then learn the non-surgical procedures. Then if you are in only consultation, then be more innovative how to handle those cases. So those who are in the cosmetic practice and in the laser, so from the cosmetic lasers move to the need-based lasers. Which are the need-based lasers? Two. One is a excimer laser phototherapy, that is a need-based. Then it's a CO2 or fractional laser, because we treat the scar and other thing where the creams want to work. So come in a need-based practice, come in the objective practice. What is objective? Objective means where the laser machine is the solution and where the creams don't work. Like in the scars, in the acne scars, in the laser hair removal, nothing else works. You need machine. So those are the absolute indications they will survive. The indication which are subjective or optional, like in pigmentary, you have a lot many other options like the peel and the cosmeceuticals and the other cosmetics. Then that may take a setback. So you may shift from the laser to the cosmeceuticals or dermaceuticals. So the hair removal, fractional lasers, all the fractional like the MNRF, the derma rollers, the fractional RBM, fractional CO2, all that category will again perform well. The Q switch and the pigment and the other thing will have little setback compared to the cost and the investment. So the youngster, please, the only problem is those millennial dermatologists who enter dermatology and they vouch themselves that I won't touch the Khas Khuzli patient and I will focus only on the cosmetology. They may get a very worst setback. So though you are focusing on a cosmetology practice, tune your dermatology knowledge, brush up your dermatology knowledge. Now focus on your dermatotherapeutics, your basic knowledge of treating, your ILS, your other injectables, your diagnostic skills, dermoscopy. So little bit come back from the pure cosmetic to the dermatology and the dermatotherapeutics. So focus on phototherapies, fractionals, laser hair removal, dermatoscopy, and other non-surgical procedures. That is my key message for the young dermatologists who want to recover from the shock of this COVID.
Okay, thank you, Nitin. You have made really very short and sweet, but the message is very clear that if you are interested in dermatosurgery, you must attain or do go for the surgery. You have to get trained by surgeon. Basic surgery you got to learn. Secondly, it is a need base. More than go for the machine. What is your need? And thirdly, you have to be focused what you want to do it accordingly. Then there is no problem of the investment, and then you are ready. Thank you, Nitin. Then we'll go for the next.
Thank you very much.
Yeah, thank you. Yeah, we'll go for the next panelist, Dr. Sardesai. Vidyadhar Sardesai is attached to medical college, and we have given him difficult subject, but he has got a very good experience about the biological, because now each and every field they talk about the biological. So Dr. Sardesai, are you online?
Yes, sir. Yes, sir.
Yeah. So can you narrate what are the limitations of biologicals, and is it essential in dermatological practice?
Well, firstly, I feel biologics are nowadays quite essential in dermatology practice. and primarily for two important conditions. One is the psoriasis, and the second is, of course, pemphigus. And the two important biologics which nowadays which we are using are the IL-17 inhibitor like secukinumab, or the TNF alpha inhibitor like etanercept and adalimumab. And for pemphigus, of course, rituximab. All of you must know about the advantages, the steroid sparing advantages, and wonderful effects of rituximab. Now, of course, as far as biologics is concerned, in psoriasis, we get so many times patients who are fed up of the conventionals, who are really fed up of the repeated testing which they have to do, the local applications, and the side effects of the conventionals. So biologics is really a very good option for these patients. uh, Important thing is the quality of life, because patients really get to experience a wonderful quality of life when biologics are given. A longer remission period, that is another advantage. But again, while saying so, I would never recommend biologics as the first line of therapy for any of such conditions. Our conventionals still hold good. The methotrexate is still the gold standard. But you have to give the option of biologicals for each and every of your patient. You can't just shut off that part. I mean, something it's very costly, and I'm not going to use it. It has a lot of side effects. No, biologics option has to be given to the patient, because nowadays patients are well read. The patients are aware of these newer treatments, and they themselves will later on ask you why you didn't give this option. You give the option, let the patient decide whether he can afford it, whether he feels like going it, and so on. Now, saying this, the limitations, yes, cost in our country, cost is the major limitation. Second, the insurance companies, unfortunately, most of the insurance companies, especially in psoriasis, do not give reimbursement for these biologicals. Nowadays, of course, some insurance companies have started giving, but otherwise, in the initial phases, we really found a lot of problems. Third is the monitoring, and especially with at the back of the mind the problem of tuberculosis in our country. So these things also you should keep it in mind. And fourth, I mean, at least personally, I feel you should take the consent of the patient. You tell him that this is not curative. This is again, you are going to control the disease, but not cure the disease. Because in our country, many a times high cost is equated with high efficacy and cure. So these are some of the limitations. And in some patients, somehow some biologics are resistant. Some you have to change the biologics. Some patients do not experience that longer remission, which is promised by certain biologicals. So you weigh the pros and cons, you take it with a pinch of salt, keep your mind open, go to the literature and use biologicals judiciously. But you can't say that, no, it's not my cup of tea. That's what I feel.
Thank you, Dr. Sardesai, and I entirely agree with you. Biological are essential in dermatological practice. We cannot stay away from that. We got to get in. And as you said, there are what is called unmet needs of the psoriasis. Many patients of psoriasis, they are not happy with whatever treatment is available. But as you said, we have to be very judicious while selecting biologicals and giving the biological. Am I right?
Yes,
That was your
absolutely.
message, no?
Yes,
You
yes.
have to be very judicious. And lastly, the tuberculosis is a big problem. But I can tell you, in HIV, this immunosuppression is so low, so high, that treating TB is not a problem. But always, if you rule out the latent tuberculosis and then you start, there are no problem. That is even my experience. So all dermatologists, they have to gear up for the biological, like that interleukin 17 inhibitor, secukinumab, TNF alpha inhibitor like adalimumab, and so on. So of course, we have to keep on learning, and you once you start using, you will realize. So don't be hesitant using biologicals. But again, I'm saying the word of Dr. Sardesai, you have to be very judicious, because nowadays they have projected there are a lot of comorbidity like a myocardial infarct, which can be preventable if we use what we call is a aggressive therapy or prevent the cytokine or inflammatory mediator. Correct, no, Dr. Desai?
Yes, yes, yes.
Yeah. Okay, thank you. So we'll go for the next panelist, Dr. Dhaval Chang from Kolhapur. And the
Hello, sir.
Yeah. Oh, yeah.
Yeah.
Yeah, so the question for you, Dr. Ganesh, that you're doing a lot of dermatosurgery.
Yes,
So
sir.
is it worth doing the OPD procedure, and is it really patients are happy and you are also happy with doing the OPD procedure, or what we call is a day care?
Yes, sir. At the outset, sir, I would like to thank this FDC people for arranging such a good webinar. And I will thank Dr. DJ Patil and yourself for involving me. So coming to the question, sir, for many years, dermatologists were practicing just a prescription practice. And it was satisfactory for the clinician, but not for the patient. Patient wants something to be done. And with the advent of dermatosurgery from last 15 to 20 years, this is now a rewarding procedure for the patient also, and something money generating procedures and rewarding procedure for the doctors also. For beginners, I want to tell a simple instruments are required for doing this dermatosurgery. A simple radio cautery unit or a electrosurgical unit. Few instruments like molluscum curettage and acne comedone extractors and cryosurgery unit. You can start with this. Especially this is rewarding for patients. The main and bread and butter of our dermatologist is acne. If you, along with giving a oral treatment for acne or topical treatment for acne, you go for a simple comedone extraction along with these procedures. Especially this works wonders and it is rewarding and satisfying. All other procedures like simple acne cyst, if it is there, you are sending to the surgeon and he is grabbing the money in large amount. A narrow hole extrusion technique with a simple punch, you can excavate this cyst and take a simple stitch. Or you can leave that graft also on the top of it and leave the patient with a simple dressing. That gives a rewarding results. Again, in acne, even these acne scars, with a simple punch excision, punch floating, punch elevation techniques, use wonderful results. Then another comes things like molluscum curettage. Just by taking away with a curettage, you can cure these molluscum people. Then there are simple things like freckles, DPNs, warts. They can be easily taken away with the radiosurgical or electrocautery unit. And patient are ready to pay, and you can show the results in a OPD just in front of them. Even with things like in vitiligo, if you do a small for gutted type of vitiligo, do microneedling. Microneedling at the hairy areas, they will induce pigmentation within 2 or 3 weeks. And people, the vitiligo patient who was frustrated by just taking this Sorelins for a longer time, if he sees a pigment, then he is very happy person and he is likely to follow you for a longer run and get cured. Then in vitiligo also, we are now going for this tissue grafting like punch grafting, blister grafting, and we are going to the tune of non-melanocyte culture transfer surgeries also with a good results, especially those people, especially for the females who are on the verge of the marriage and they are not getting married because of such a vitiligo lesion. So they are very much satisfied. Then there are lesions like pyogenic granuloma. Just with a artery forces, you crush the base of the lesion, and it is very simple to take away with the electrocautery unit or radicautery unit. So they can be just instantly stopped. There is one lady which had come to me that a 70-year-old lady was brought by her son. Her whole pillow was become reddish because of this pyogenic granuloma in the scalp. She was not knowing. And when she came to me, I gave her just local, crushed the base of the lesion and took out the electrocautery. and everything was stopped. So such is a magic and wonderful results, rewarding results. Even with nail surgery, if you go to nail surgery, those people are having a ingrowing toenail and causing a chronic pyonicrea. You just take a lateral nail avulsion surgery do and just apply a sticks with a tricarboxylic acid or phenol, just for that matter. It gives you excellent result. Bleeding stops, their pain stops, their pyonicea goes, and the nail that grows, it is cosmetically appealing to the person, and all problems are solved with this in the nail surgery. Even simple, if you have a cryosurgical unit, those people who are on the verge of marriage and having a nodulocystic acne, doing a cryo slush for every 15 days or every weekly also, the nodules just vanish, even just by puncturing these nodules and doing a cryosurgery. So then there is a keloids, especially the keloids, rewarding keloids are earlobe keloids. Just take them away and they will heal like and you can restore the shape of the ears also. And then go on injecting intralesional steroid at least once in a month for initial few months. And then have a touch-up sessions after every 6 months. There is no recurrence of earlobe keloids. Even we do the keloids on the chest, especially on the sternum also, with the cryosurgery and the intralesional steroids. Or this, they give a excellent result. So many things are now, especially simple scalpel if you have and blade. You can shave off these moles. Even simple razor blade you have. Give a local and just with the hook you can take away these moles. So many things are nowadays can be done. Even milia, a simple pointed probe can destroy the milia which are around your eyes, and the patient is happy after 15 days. Everything is gone. Even the surgeries like sebaceous cyst on the scrotal area, people come with a big 15, 16, 20 cysts. Just by evacuating the cyst within just taking a puncture, they are much happy after within no time. So what was your question? Whether it is a rewarding to go for a dermatosurgery? Yes, 100%. I will.
Thank you, Dr. Dhaval Chand.
I will say
you are really given a good message that most of the patients, they come to a dermatology practice, they need dermatosurgery or the minor procedure, which you can do it. If you do not do it, they will go away from you, and which easily, and there is hardly any investment.
Yes, sir.
You mentioned,
And that one point I want to highlight. For such a new era, you have to build so much clinics, so much money is involved nowadays, interior of the clinic, all these things. And for a beginner to have a good amount of money, just how much consultation you can take such a place like Kolhapur, not more than 500 rupees. But you can go for dermatosurgical procedures, people will pay you in thousands. So that is a very good thing.
You mean is you can increase your revenue easily by doing the procedure?
Yeah.
Correct, no?
Very
very good. Thank you. Now we'll go for the last panelist, Dr. Dhananjan Damble, which is well known. He was a secretary of Dermacon in Pune, and I must thank him. The whole program has been coordinated by him. He has worked very hard for this program, contacting all panelists, discussing them and time. Sorry, I have forgotten Dr. P.D. Joshi. So first, I think I'll finish with Dr. P.D. Joshi. P.D. Joshi is again my contemporary from Grand Medical College, JJ Hospital. He is practicing in Nanded. And Dr. P.D. Joshi, everybody is talking about clinical dermatology. What is your message as per the social work is concerned by the dermatology? They should get involved or they should not get involved?
Indian Association of Dermatology, Venereology and Nephrology itself is a registered organization under Charitable Commissioner Act. It means that in a broad sense, IDVL itself is a NGO under the Act of 1860 and 1950. And by what we mean, really NGO means actually such an organization which take the government funds. But according to the Charity Commissioner Act, IDWL is a NGO. But we say the organizations like IDWL, they are not, we call it an NGO, although according to the government record they are, we call them as a self-motivated organizations. We divide NGO in two parts in a broad way. One is the service organizations which run the schools, education institutes, home for aged, and hospitals. Second, the part of the NGO is advocacy organizations, which give proper direction to the governments in terms of innovations and implementations. In India, if you calculate the total amount turnover of the charitable institutes is around about 250,000 crores. And in Maharashtra, 50,000 crore is their total turnover in annual turnover. Why should we work for NGO type of the works? That questions arises to the many dermatologists. But there is one sentence by Winston Churchill: we make living by what we get, but we make life by what we give. There are many activities which the dermatologists can do. They can be lead the society itself by doing the many of the organizations. What I mean, the dermatologists should go for the research, that is the advocacy. They should go for the innovations, and we should build the youngsters as a budding dermatologist for a good nation. They can create the awareness programs in the society. They can go for the television, they can go for the All India radios, they can write the articles on various subjects concerned with, and they can have the Facebooks and WhatsApp groups too. There is many of the days IDWL celebrates. These are the national and international days that we have to celebrate. The IDWL Day, Anti-Leprosy Day, and a week. Vitiligo Day, Psoriasis Day, Anti-AIDS Day. There are many of the days we can celebrate in a year by writing in the local newspaper and by going to the community. The main activity which the Dr. Venkat Mysore has started in this, when he was a president, was a community of dermatology, by which we can go to the rural places, can take the camps, we can serve the poor, we can serve the home for aged, we can serve for the jails, and it has an activity which to be focused for the awareness that many of the states have started, because for that only we are getting the patients of the dermatophytosis more. By utilizing this, through all the media by which we are having, we can go in the society and we can enlighten ourselves. Actually, when in 1977, the many of the faculties were open for me, I chosen the dermatology purposefully to serve for the society, because it is a non-emergency branch which I thought at that time. And what I am doing mainly work in the leprosy as for the IDWL is concerned. I take CMEs along with Dr. Pai, Dr. Bhatki, Dr. Deepak Kulkarni, Uday Thakar at various places in Maharashtra. I do the surveys for the leprosy patient in many of the districts in Maharashtra. And we give the calipers, chappals, slabs to leprosy patients. And we give financial help to support and to rehabilitate the leprosy affected patients. I work for child laborers in Maharashtra. I rehabilitated 17,000 of child labor by this time. The great Nobel Prize winner, Honorable Kailash Satyarthi, rehabilitated 86,000 child laborers. I have rehabilitated 17,000 child laborers. I run the child labor schools at various places in Maharashtra. My main areas of interest in which I work as a dermatologist and as a social worker is a self-help group for women I have 1,200 groups, means around about 1,20,000 women with us, and we have formed a bank for them to rehabilitate poor women by giving them the money for rehabilitations. We have got a child line 1098 which can be dialed from any part of the India, and we go for rescue for the child. The Home for Aged is built at Nanded, is working since 30 years. We go for the watershed programs at Nanded and around.
Yeah, I
By
think
this time, we are.
PD, sorry, I had to intervene here. I think after listening to you, you have given the message, you opened the new topic to dermatologists. And I feel whenever I get the opportunity, I'll call you as a speaker because it's worth listening to it. I remember my son used to say, Daddy, you are doing good work, you are treating patient. But if you convert your work in the community services, I think that will be the higher work. That's why my son used to tell me, of course, I am also like you are doing, but I think we'll definitely, whenever get the opportunity, I'll see that Dr. Joshi will be invited as one of the main speaker, and even I'll suggest to IDWL also. So because of time constraints,
Thank you for the opportunity to talk in the area in which I am interested. Thank you.
Yeah, no, it's a really nice one. Dhananjay, any panelists is remaining or can you go with you?
No, sir. I think we are done with all.
Okay, again, I'm repeating. Thank you, Dhananjay, for the coordinating, bringing all panelists together, talking to them, getting their information, area of interest. I must thank you for that. It's a wonderful work, but we cannot close it without asking your expertise. So now we are talking, the acne is very common, but in acne, the common problem, the scars, they come for the scars. So how do you approach or how do you manage these patients?
At the outset, sir, let me thank you for giving me this opportunity. It was worth the wait for my turn after listening to so many eminent co-panelists who had their own views on so many varied topics, which I think most of the people who are hearing this out must have benefited with. Now, coming to your question of acne scars, basically acne scar therapy starts the day the patient walks in your clinic, because the first part is to prevent the scar, and if unfortunately patient lands up in the scar, to treat them. So the prevention part is very, very important, and it can be done wonderfully well by assessing the patient on day one, taking help of retinoids, topical as well as the systemic ones, grading the patient accordingly, because the more number of months or years the patient has inflammatory acne, the more are the chances of patient landing up with scarring. And scars, as you know, cannot be of a single type. There are so many types of scars, multiple combinations scars. So the treatment can also not be a single line of management. You need to use variety of methods or combination of treatments to treat an individual. Suppose there is an ice pick scar, the best method that works is TCA cross. I don't think lasers work for it. If you have got rolling scars, box scars, then you have a variety of methods to use. Either you can use a subcision, or you can use PRP, you can use energy-based devices, you can use lasers. But ultimately, at the end of the day, you have to use multiple therapies to treat a person with a scar. And important point is to counsel these patients on day one that the scar therapy is not like a magic wand. He or she has to undergo multiple sessions, and actual end result will be only visible at the end of maybe 8 to 10 months or sometimes even a year, depending on the depth or depending on the extent of the scar. This is what is my take, because I feel scar prevention and scar therapy, they both should be part of strategy to manage acne scars. Thank you, sir.
Okay, thank you, Dhananjay. Again, you have made it very clear when you're talking about this acne scar. Just treating acne scar is not difficult if we follow the combination treatment. Secondly, the more just treating is not enough, so you go for the prevention. That is a very good message. And I think we have come to the end. Before we ending, I think I must thank to all panelists, especially Dr. DJ Patil. In spite of probably you may not be knowing, Dr. DJ Patil is running 79 years. He is quite senior. In spite of that, always he looks like a young person. And he agreed and he came for that. So I must thank Dr. DJ Patil, all panelists. It was wonderful. At least I've learned many things. And now I'll hand over to Dr. Mukadam for the vote of thanks. Dr. Mukadam, you are mute. And of course, Fdc-Zocon for their cooperation and making this program successful. Yeah, Khalil. Yeah.
Yes, sir. Thank you very much, sir, for such a wonderful webinar. The way you conducted it, sir, and it was very nicely organized. Thanks to you, Dr. Dhan. Special thanks to Dr. Dhananjay Damle for coordinating, and it was very wonderful to see that all the experts and they were up to the point giving their opinion, and they really it was very educative, and I myself learned a lot from all of these experts, sir. Before I thank them, I request Mr. Shailendra Marna of Fdc-Zocon to play a stream the video for the bidding, sir. Just for a few seconds.
And yeah, okay. Yeah.
It's a video of
yes,
our
yes, correct.
venue, sir. It's mute.
May I thank Dr. Saple,
Yeah.
Mukadam,
Sir,
and
sir,
FDC for inviting me. Thank you very much.
No, sir. Please see this video, sir.
Yeah.
This video.
What about the sound?
Sound.
Oh, it's beautiful.
Hello. Sound is not there.
Okay, sir.
Thank you very much
Really beautiful.
for just giving time, and really it's a worth seeing this video of the venue, and I hope everybody will be convinced that this Geo Convention Center is one of the best, and Mumbai can offer the best conference, Ramakon International 2023, in all aspects, right from the city, from the point of view of convention center, from science, and from entertainment. So now my first and foremost, my thanks to Dr. D.J. Patil sir for being present here and for and really uh, giving his most of his best experience, and by saying that this is worth Mumbai trying Mumbai for the Ramakon International 2023. So Dr. Sapne sir, Dr. for organizing such a beautiful webinar, Dr. P.D. Joshi sir for his participation, Dr. Dhanashri madam. Then I'm very happy to have here Dr. Rashmikant Shah, National IIT, and Dr. Manish Gautam, who is the one of the most prominent member of bidding team of Mumbai for Damakon International 23. It was very heartening to have Manish along with Rashmi. Then we are all stalwarts of our dermatology, dermatosurgery, and laser surgery, along with the Dhananjay Chavan, Mr. Ganesh, Dhaval Shank, then Dinesh Oswal, Vidyadhar Sardesai, Dipti Desai, Dr. Dipti Desai, Dr. C.K. Mathur, Dr. Dr. Dr.
Shailendra, there are a lot of
and I
sounds.
hope I'm not mentioned Dr. Urshwa. I'm very thankful to have all of them, and they really inspired all of us to have more such webinars. And I request Dr. Sapre sir to have many more such webinars where each part of our Maharashtra is included. All the stalwarts from each part of our Maharashtra are included in this, and it is really very happy to see all of them in action. Thanks a lot, sir.
Sir, I think you're on mute, sir. Sapre sir is on mute. Sapre sir is on mute.
Thank you very much. Khalil, thanks a lot.
Thank you everyone.
Thank you, everyone.
sir.
Thank you. Thank you so much.
Bye-bye.
Thank you. Bye bye. Thank you so much. Thank you, Sapne sir.
Thanks a lot.
Thank you, Dhananjay, for arranging this. Thank you.
Thank you, Dhananjay sir. Bye, Manish sir. Bye, Mukadam sir.
Cheers for Kojagiri.
Yes,
Thank you.
thank you,
Thank you.
Aditya sir.
Nice seeing you after a long time.
Yes.